In the human body, physical and cognitive aging is defined by a progressive narrowing of the metabolic window. Over time, the dense, microscopic capillary networks that feed our tissues simply shrink and prune back, a process known as capillary rarefaction. As these tiny vessels disappear, they create a chronic supply-demand mismatch. The surrounding tissues are left chronically starved of oxygen and nutrients, slowly suffocating both neuronal activity in the brain and cardiovascular function in the heart. Reversing this structural loss has been notoriously difficult, but emerging clinical research reveals a startling anomaly. Subjecting patients to brief cycles of fluctuating oxygen levels can force the body to rebuild these lost vascular networks. This animated chart shows a 2019 clinical trial on elderly patients with mild cognitive impairment. Instead of a downward trajectory of cognitive decline, patients who underwent intermittent oxygen therapy experienced a sharp 20% improvement in their Montreal cognitive assessment scores. Looking at the peripheral biomarkers from the same protocols, we see the physical mechanism behind the cognitive rescue. The treatment triggers the bone marrow to mobilize CD34-positive stem cells into the bloodstream at 3 to 8 times their normal baseline rate. These outcomes are notable for their breadth. While many targeted pharmaceuticals address isolated symptoms, the IHHT protocol induces a coordinated response across the cognitive, vascular, and hematopoietic systems simultaneously. Repairing capillary rarefaction requires a systemic regenerative signal. Researchers have found that signal by manipulating the delivery mechanics of the most basic molecule in human metabolism, oxygen itself. The core conceptual framework driving these regenerative results is known as the Hyperoxic-Hypoxic paradox. For decades, clinical medicine operated on a seemingly logical assumption. We believed that cellular machinery only measured the absolute static concentration of oxygen circulating in the blood. Current data proves that assumption incomplete. Cellular oxygen sensors are actually highly calibrated to react to the velocity of change. They measure the gradient in oxygen tension. If you place a cell in a state of oxygen saturation, or hyperoxia, and then rapidly drop it back down to a normal baseline, the cell misinterprets that sudden downward slope. It reacts to the steep drop exactly as if it were receiving the physiological signal for severe, tissue-threatening hypoxia. This provides an immediate, tangible clinical benefit. By utilizing this gradient, clinicians can trigger deep hypoxic adaptation and regeneration without ever exposing frail, elderly patients to actual dangerous oxygen deprivation. What we call a paradox is actually an evolutionary mechanism designed to measure gradients, providing a reliable method to engage the body's systemic repair systems. To understand how this works, we have to look inside the cell and identify the specific molecular machinery acting as the body's oxygen gatekeeper. The master transcriptional regulator for regeneration is a protein called hypoxia-inducible factor 1 alpha, or HIF1 alpha. Under normal baseline oxygen conditions, HIF1 alpha is constitutively produced by the cell, but almost instantly it is targeted for destruction before it has a chance to act. The actual oxygen sensors regulating this destruction are enzymes known as PhD. They grab ambient oxygen molecules and use them as a necessary co-substrate to attach a chemical marker onto the HIF1 alpha protein. Once that marker is attached, the VHL ubiquitin ligase complex locks onto the HIF1 alpha and drags it straight to the proteasome, where it is shredded and degraded. But in a hypoxic state, when absolute oxygen levels drop below a critical threshold, this process halts. Without ambient oxygen to use as a co-substrate, PhD activity is inhibited. Untouched by the PhD enzymes, HIF1 alpha stabilizes. It translocates into the cell nucleus, where it binds to DNA and activates over 200 regenerative and angiogenic genes. These PhD enzymes function as the molecular brakes on regeneration. Inhibiting their activity is the mandatory first step for triggering vascular repair. Intermittent hypoxia-hypoxia training, or IHHT, is the clinical protocol designed to engage these molecular brakes without risking actual hypoxemia. This graph tracks a patient's arterial oxygen saturation over time during an IHHT session. The critical therapeutic intervention comes next. The enriched oxygen is suddenly withdrawn, rapidly switching the patient's breathing mixture down to a mildly hypoxic level. It is the sheer steepness of this drop, the delta, that triggers the sensors. The cell isn't looking at the absolute bottom number, it is measuring the speed of the descent. The extreme velocity of this oxygen gradient temporarily overwhelms and inhibits the PHD enzymes. The molecular brakes are applied, mimicking the physiological conditions of suffocation. This precise drop achieves HIF-1 stabilization, even while the absolute oxygen levels in the frail patient's blood remain safely above lethal thresholds. Hyperoxia acts as a pressurized spring. The sudden release of that pressure is the mechanical trigger that drives HIF-1 into the nucleus. The most common clinical misconception surrounding this therapy is the tendency to equate therapeutic intermittent hypoxia with the pathological hypoxia observed in obstructive sleep apnea. This chart illustrates the toxic dose profile of sleep apnea on the left. It consists of 30 to 120 erratic, uncontrolled desaturations per hour, lasting entirely through the night. This high-frequency chronic pattern drives systemic inflammation, hypertension, and pushes the sympathetic nervous system into overdrive. Contrast that directly with the IHHT dose profile on the right. It utilizes a low frequency of only 3 to 10 cycles. These are strictly controlled, moderate desaturations, contained within a brief 45-minute window. The specific advantage of replacing standard room air with a hyperoxic recovery phase is speed. It rapidly restores arterial saturation, safely permitting robust cyclic training even in frail patients with compromised cardiopulmonary function. Additionally, these controlled hyperoxic pulses generate mild bursts of reactive oxygen species. Rather than causing oxidative stress, these short pulses act as signaling molecules. They activate the NRF2 pathway, boosting the body's endogenous antioxidant defenses. Oxygen behaves precisely like a drug. The dividing line between a degenerative cardiovascular pathology and a neuroregenerative therapy is governed entirely by the dosing protocol. Once the dosing protocol successfully pushes HIF-1 into the nucleus, it triggers two primary downstream physiological cascades. The first is a structural vascular cascade. The stabilized HIF complex binds directly to target genes that upregulate the secretion of vascular endothelial growth factor, or VEGF. VEGF acts on nearby blood vessels. It stimulates endothelial tip cells to migrate, degrade the surrounding matrix, and sprout forward to form new capillary networks. This VEGF-driven angiogenesis physically replaces the blood vessels lost to aging. It is the direct reversal of the capillary rarefaction that drives cognitive decline. The second cascade focuses on fuel efficiency. The moderate hypoxic troughs act as a stress test, triggering targeted mitochondrial quality control. This initiates mitosity. Dysfunctional mitochondria, failing to maintain membrane potential during the hypoxic stress test, are engulfed by cellular vesicles and cleared from the cell. The IHHT protocol simultaneously rebuilds the structural delivery system, the microvasculature, while upgrading the mitochondrial engines receiving the fuel. Despite the clarity of these molecular mechanics, the broader clinical literature frequently reports mixed results regarding hypoxia studies. This chart illustrates why. It's known as the ceiling effect, and it is observed heavily in trials involving healthy, neurologically intact young adults, where cognitive and vascular gains remain near zero. High-performing biological systems are already optimized. Intermittent hypoxia acts as a corrective tool, meaning it has little to fix in healthy youth. But in geriatric and mild cognitive impairment patients, the therapy yields massive vascular and cognitive gains. The clinical value of intermittent oxygen modulation is unlocked specifically in populations suffering from age-related homeostatic decline and existing vascular dysfunction. In a landmark study on the AVIV protocol, researchers demonstrated that extended, controlled oxygen fluctuation therapies significantly lengthened chromosomal telomeres and reduced the total count of senescent cells in aging patients. To achieve these specific outcomes safely across frail populations, clinics must utilize modern, automated biofeedback devices to precisely individualize the hypoxic dose for every patient. By utilizing the mechanics of the oxygen gradient, geriatric medicine can directly engage the body's existing biological machinery to drive cellular renewal.